I'm now pleased to introduce our next speaker, Dr. Will Cefalu, whom I first worked with when he helped initiate this Precision Medicine and Diabetes initiative as the Chief Scientific Medical Mission Officer of the ADA, and whom I actually still continue to work with here at NIDDK, where he's serving as the Director for the Division of Diabetes, Endocrinology, and Metabolic Diseases. He'll be sharing his perspective as well as NIDDK's approach to precision medicine. Unfortunately, he's not able to join us in person for Q&As after the talk, but certainly if you have suggestions or comments, please do make them in the chat and I share them back with him at NIDDK. And I'll turn things over to run the video.
Thank you very much. Thanks for the invitation to participate in the Precision Diabetes Medicine 2021 conference. My topic is precision medicine and the research agenda for diabetes. I have no conflicts or disclosures to be reported. The promise of precision medicine diabetes will provide for validated biomarkers to inform on subtypes and improve diagnosis and classification. A precision medicine approach will provide for more targeted interventions for prevention. It will provide for more precise and targeted therapeutic and behavioral strategies for management. And it will provide for early identification and more effective prevention of complications. But to really realize the potential of precision medicine, we really need to understand the subtypes and improve the diagnosis and classification of diabetes. When we look at the major causes of classification of diabetes, we have type 1 and type 2, and this has not changed for many years. And we know there's common features between the two. There's autoimmunity in type 2, there's obesity and insulin resistance in type 1, and inflammation in both. And we know there's tremendous heterogeneity in diabetes and these so-called subtypes of type 2 diabetes. For example, when you look at the individual to the right, he's leaner, diagnosed recently, on insulin therapy sooner, and develops these complications over time. The gentleman to the right, a little bit older, has had diagnosis for 10 years, overweight, controls on metformin, and no complications. Yet both are classified as having type 2 diabetes based on the glucose levels. So moving forward, we need to understand how these subtypes can help us predict clinical course and best treatment, and really how to apply precision medicine approaches to type 2. For example, in monogenic forms of diabetes, we have a single gene disorder, and we can prescribe a precise therapeutic intervention to address that condition. This is a true precision medicine approach. For type 2, it's quite different. Individuals vary in the degree of insulin resistance. Individuals vary in the degree of beta cell dysfunction, hepatic glucose production, behavior, obesity. So it's difficult with such a complex disorder to have precise treatment. In fact, our treatments today, anti-hyperglycemic therapy, is really based on population mean response from these studies. So when we look at the arsenal of drugs we have, the good news is that we have many agents today that are able to effectively treat type 2 diabetes. And in particular, the SGLT2 inhibitors and receptor agonists have metabolic effects beyond A1C, which have allowed us to change our standards of care. But the difficulty with having so many choices is now increases the issue of the heterogeneity in the treatment patterns. So let's talk about standards of care, and let's talk about how it has evolved to more individualized care. Let's start with 2017. Clearly, treatment is dictated based on A1C. Less than 8% monotherapy, 9% dual therapy, greater than that, combination injectable therapy. Metformin was indicated as the first-line agent, and it's a stepwise approach. But you can see the complexity now. What is the best agent to use after metformin? What parameters do you use to suggest that agent? So variability in the system at that point. When we go to 2018, it began to change. Once again, making the treatment decision based on the biomarker of the disease, the A1C. Monotherapy with metformin, but at that particular time, not only was it stepwise, but now adding an agent to reduce major adverse events based on the evidence accumulating at that time. In 2019, an additional tweak to the system. Yes, setting the target for A1C. Once again, assessing the target for A1C as the initial goal. But here is where we begin to consider other aspects. Consider development of complications such as atherosclerotic disease, cardiovascular disease, heart failure, chronic kidney disease. If there's hypoglycemia or an issue with weight, that would begin to dictate the next step in therapy. So once again, becoming more individualized as we move forward. In 2020 was another significant change. Here is where you would consider the next step in therapy independent of the A1C. This is, to me, a significant paradigm change because it shifted on research evidence and you're selecting therapy based on the risk and development of the complications and not the specific biomarker of disease. And in 2021, this changed even further, now further stratifying of the complications that we see. So based on these individualized guidelines, really there's two questions. Are the more individualized guidelines making a difference in clinical decision making? Or with the guidelines, are we moving to more precise treatments on a clinical level? And before we can answer that, we really have to address two other issues. The first issue remains in the heterogeneity in the pathogenesis and progression of the disease. Because currently today, we know that there's heterogeneity between youth and adolescents versus adults and adults versus the elderly. And as we've talked about today, there's subtypes of type 2. So there's great heterogeneity in the disease itself. Secondly, the heterogeneity in the clinical treatment patterns based on the number of drugs that we have available to use. So there was an interesting study just this month that Dr. Atul Butte and his group published in Diabetes Care, and it assessed real-world practice patterns. In this paper, they took advantage of over 5 million electronic health records in patients in the University of California Health Data Warehouse. From that, they filtered down to get their cohort. They used a filter where the individuals who had prediabetes or type 2 or A1C, that represented about 530,000. Then they eliminated those that indicated type 1 or pregnancy, 364,000. Or for that matter, then they got to the point to where did a UC medical system provider initiate an anti-hyperglycemic medication, and that was 97,000 patients. And you can see these were stratified on initial therapy. Then they created these lifesaver plots. This is a complicated plot, but let me walk you through it. This first ring indicates initial suggested therapy, be it monotherapy or combination therapy. And you can see the color scheme, orange here for metformin, insulin, the DP4 inhibitors, sulfonylureas, and you can see the various options for that initial therapy. Now, the second ring refers to the second treatment strategy change. And now you can see if the color remains the same, no change, but then you can begin to see these changes with this second treatment step, indicating a change in treatment. By the time you get out to the third ring, you can see more various options. Now, each of these lines indicate a single patient, and you're beginning to appreciate the variability. Overall, in this study, tracking the first 4 medication changes for 97,000 patients, 12,000 unique treatments. And the authors in this study suggested that treatment of type 2 in real world has tremendous heterogeneity and practice patterns. So this is an important concept when we talk about precision medicine approaches. Now, part of the problem may be that we need to do a better job of classifying diabetes. And this slide was adapted from a nice perspective done by Prasad and group just a few years ago, starting with the diagnosis of diabetes in 1939, dividing it into insulin sensitive and insulin insensitive categories. The proposed change in 1979 by the ADA into type 1 insulin dependent, non-insulin dependent, and endorsed by the World Health Organization in 1985. It was not until 1975 that the first use of the term MODI was used, and molecular underlying causes not described until 20 years later. LADA was described in 1996, and in 2007 were the first GWAS studies, termed at that time the breakthrough of the year, with a real understanding that now we'll be able to tease apart diabetes, particularly as it relates to classification. But what's happened on this time is that we still classify and diagnose diabetes with one metabolite, and that being glucose. It's only been the last couple of years that we've been to looking at the subtypes and defining novel subgroups of type 2 and associating these subtypes with outcomes. The idea here is the clustering concept, and here's an interesting proof of concept that was done years ago. This particular group took electronic health records on the left, about 11,000 patients, and began to look at patient similarities. And you can see the colors aggregate with the patient similarities, either phenotype or laboratory abnormalities. However, on the right, in 2,500 individuals with type 2, they were able to show association of this phenotype with genetic variants. And so on the right, they identified 3 subtypes. Subtype 1, aggregated with complications such as nephropathy and retinopathy. Subtype 2, cancer malignancies and cardiovascular disease. Subtype 3, cardiovascular disease, neurological disease, and allergies. Now, this is a very complicated analysis. The question is this applicable at the time of diagnosis, and can it be used by a provider? This is where there have been some steps taken to look at more simple clinical variables as a way to subtype the patient. And this is from group and colleagues' work from a few years ago in Scandinavia, where they looked at these 6 cluster variables: GAD antibodies, age, body mass index, A1C, markers of insulin secretion and resistance. And in their cohorts electronic records and following these patients over time, they identified a subtype: severe autoimmune diabetes, low GAD antibodies, low insulin secretion, poor metabolic control. They identified this would be the type 1 or the LADA. Then a subtype in type 2, 4 subtypes: severe insulin deficient diabetes, low insulin secretion, no antibodies, poor metabolic control, increased risk of retinopathy. A severe insulin resistant diabetes, marked insulin resistance, obesity, marked increase of nephropathy and fatty liver disease. And then 2 moderate obesity related diabetes. The concept here is by looking at these simple clinical variables and defining subtypes, that you can now look at the natural history and understand that complications may be greater in some of these subtypes. And if so, the idea would be maybe you can define therapy earlier on to mitigate those complications. Now, there's been great interest in these subtypes over the years, and many of these subtypes have been validated in other populations. But there's been alternative strategies also. In addition to the 5 subtypes, Dennis and his group a few years ago suggested that, well, maybe you can use clinical features such as age and renal function to also come to the same conclusion. And in their study, in addition to looking at the cluster groups, for example, they looked at continuous age of diagnosis and showed that this was able to stratify glycemic progression. Taken together, these studies looking at these variables and beginning to provide an understanding of the subtypes are the first steps to understanding how we can best treat the heterogeneity of diabetes. So as my talk is on precision medicine and research, let's talk about the Precision Medicine Initiative from the NIH. As you know, President Obama launched the Precision Medicine Initiative at the NIH in 2015 in an effort to bring us closer to curing diseases like cancer and diabetes. And as you know, this program called the All of Us is going to be a very comprehensive program with significant patient interaction. Patients go to the portal, enroll, they allow use of electronic health records, they volunteer for genotype and phenotype assessments, with the goal being that this will allow us to discover genetic and environmental correlates of disease, improve predictions of therapeutic safety and efficacy, discover disease biomarkers, and more importantly, develop new disease classifications. And we hope that's going to be applicable to diabetes. What we have today in NIDDK is our Radiant Network, Rare and Atypical Diabetes Network. Dr. Christine Lee, who is serving as the moderator of this session, is overseeing this program. This is to identify patients and families with novel, rare, and atypical forms of diabetes and characterize the underlying molecular mechanism. To do the genotypic and phenotypic characterization of these patients, to have a biorepository available to the scientific community, in the hopes that this will allow further understanding of the subtypes and hopefully at some point down the road help us in the reclassification. So I'm very excited about this particular program, and I think it's going to inform greatly on the heterogeneity of diabetes. So I'd like to close and say, I am very optimistic, and I think the future will be one for which the promise of personalized medicine will be realized. I think key steps do revolve around more precise diagnostic classification of diabetes and identification of subtypes before we can fulfill the promise of precision medicine. And regardless of the technological advances, individual patient preferences will still need to be considered and patients will remain at the center of care. And finally, medicine is an art, it's not a science. And success of precision medicine will depend on the provider understanding of this approach and the patient interaction. And we do need to address the heterogeneity of treatment patterns. So thank you again for participation and allowing me to participate in this conference.
And so, as I mentioned before, unfortunately, Dr. Cefalu could not be with us here in person to answer any questions that might come from our audience. I certainly can bring questions and comments back to him. And I don't know if Dr. Nolan, you have any observations that you would like to share or questions you have that I can address or bring back to Dr. Cefalu.
Well, I think it's a great talk by Dr. Cefalu, and he really has helped to lay out the field for heterogeneity. Just one quick question because of time, Christine, is the Radiant program. He mentioned that you're involved in that. Can you say a couple of quick words about that so that people would understand more of what it is?
Sure, I'm really excited about this project as well. We actually launched, believe it or not, in the middle of the pandemic this past September, and so started enrolling participants virtually for Radiant. And have done quite well so far. We hope to enroll close to 2,000 participants in the hopes that at least half we will discover a new novel form of diabetes that can help inform us on subtypes that might be present in this broad bucket that we call type 2 diabetes right now. We are planning to do whole genome sequencing on those individuals as well as RNA-seq, and for some select few, when indicated, mitochondrial sequencing. And there's a very comprehensive physical exam, assessment of insulin sensitivity and secretion, banking of a variety of samples, as well as important data on patient-reported outcomes and things that matter to the patients that participate in our study. And so that's a brief sketch of it. There is a website as well that people can go to or contact me, and I can share that with others if they're interested. Thanks for the question.
Great. That's really terrific. Really interesting to hear about that.